Hi, everyone, and welcome to today's webinar hosted by Pallium Canada. It's fantastic to have you all from right across the country, hundreds of people joining us. Welcome. I think we're in for a treat today. This is actually a very special webinar for several reasons. Firstly, the topic. 7 keys to delivering palliative care upstream, which captures the voices and experiences of patients and families. And clinicians right across the country have been recognizing the importance of starting palliative care much earlier in the illness trajectory. Well, we're going to get some tips today on how we can help with that. And these are keys and tips that come from patients to help us with that messaging and with that approach. Secondly, we have 2 amazing guests and presenters, and I can't wait to introduce you to them. It really is a treat to be introducing them, I must say. Thirdly, and for Pallium Canada, this is very exciting. It's Pallium Canada's first ever ECHO session, and a little bit more about that very shortly. I am José Pereira. I'm a palliative care physician, and I'm professor and director of the Division of Palliative Care in the Department of Family Medicine at McMaster University, and I'm also scientific officer of Pallium Canada. Next. So Project ECHO, which actually stands for Extension for Community Healthcare Outcomes, was first developed in 2003 at the University of New Mexico. And it had its roots in that there was an outbreak of hepatitis C in a part of New Mexico, more rural and smaller communities. And the healthcare professionals in those communities did not have access to specialists who really knew how to handle the disease. So they set up the ECHO program whereby primary care professionals could connect with specialists who really knew how to manage the problem. And so what happened was that they then used these opportunities, these ECHO sessions, to present the cases, get advice from the specialists on how to manage them and how to deal with them. And at the same time, it became a learning moment. So that concept is now spread internationally. And Pallium Canada is now funding Health Canada is now funding Pallium Canada to support the ECHO palliative care in the country. Now, it doesn't mean that this program with Pallium is replicating or replacing existing hubs. There are already ECHO hubs across the country, including a fantastic hub for pediatric palliative care out of Sick Kids. And we would really encourage you to look at that if you are caring for people, for children. I think that's a fantastic hub to go to. The idea of the Pallium Hub is to fill in the gaps and look for other opportunities to broaden and spread the palliative care approach across the country. So ECHO will be used to create largely virtual communities of learners who are then able to provide better care to patients in their communities. And it uses video conferencing technology and a hub and spoke education model to connect healthcare providers in the community. So these are the spokes with teams of specialists and experts at regional or national centers, which are the hubs. It will not replace the LEAP program, but provide opportunities for deeper dives in different areas, and it will be supporting communities of practices. Next, please. So it's a 5-year national initiative led by Pallium Canada and its hub partners from across the country. The first hub partner, so in the first phase, will be the BC Centre for Palliative Care, the Canadian Long-Term Care Association, and the Canadian Home Care Association. So we're really thrilled to be working with them to develop hubs. They will be overseeing those hubs and using those hubs to scale and spread their various activities across the country. Before we get to our main event of today, as it were, I've got to share with you some housekeeping. So we'll go on to the next slide. That's it. So your microphones are muted. You can imagine having hundreds of people from across the country. It's pretty difficult to unmute everyone. However, please do raise your hand if you've got a question or comment to make. And at this end, the organizers will open it up for you to chat. Do use the Q&A function of Zoom. There is also a chat function, but we'd ask you please to use the Q&A function, which is at the bottom of your screen. And like that, we can respond, we can track the discussions easier. So please do feel free to tap the expertise of our presenters today. Now, this session is being recorded and will be mailed by email to all of you after the session. Next, please. Very quickly, we've got to declare any potential conflict of interest. Just to let you know, Palliative Canada is a non-profit organization, partially funded through a contribution by Health Canada, and the ECHO program is fully funded by Health Canada. Pallium also generates some funding through its course registrations of its LEAP courses and the sales of its Pallium pocketbook. So now, as a moderator, I'm paid as well by Pallium Canada in my role as scientific officer. Doctors Winemaker and Seow have got no conflicts of interest to declare. Next. I don't think I need to present myself again or introduce myself again, so we can go directly to our fantastic folks today. And it's a great pleasure to be welcoming Dr. Samantha Winemaker and Dr. Hsien Seow. Sammy is a palliative care physician who works in the Hamilton region and one of my colleagues there. She's associate clinical professor in the division of palliative care in the Department of Family Medicine at McMaster University. And Hsien Seow is associate professor in the Department of Oncology, also at McMaster University, and Hsien holds a Canada Research Chair in Palliative Care and Health System Innovations. They are both amazing people. I have had a pleasure and honor working with them and collaborating with them over the years. Not only do they bring incredible expertise, passion, insights, but they also both bring this incredible level of energy. And I don't know where they get that energy from, but I'm sure we'll all feel it as the presentation moves on. So at this point, over to you, Sammy and Hsien.
Thanks so much, José. Hi, everyone. We had these learning objectives, but I think, I'm really pleased to be here. I know it's a busy time in healthcare. We appreciate everybody's time. And we are really excited to chat with you today because both Sammy and I have been working so hard on trying to figure out how to go upstream and how to improve the lives of patients and families, particularly through palliative care. And we have come up with a project. It is a podcast. We're going to talk a little bit about the podcast, but really the story behind it and what we talk about in our first season. And I think to start off, I'm going to pass it to Sammy to really just start with the problem we were trying to solve and really maybe sort of the origin story of where our ideas came from.
Thanks. Thank you, Hsien. So I'm going to invite everyone at this time to come on a home visit with me. We're going to meet someone named Jerry, a 52-year-old with idiopathic pulmonary fibrosis, which is a progressive lung disease. And he lives in this home, and we haven't met him before. We know that his illness carries an average life expectancy of between 2 to 5 years. We learned when we were reading up on him that at his last appointment with his respirologist, he was delivered devastating news that he would not have a lung transplant. And he had been really hoping that that was going to be the outcome. Having had his only hope taken away, he felt no other option or choice but to formally request medical assistance in dying. It's 2016, the year that MAID became legal in Canada, and we are meeting Jerry for the first time. So we approached the door of his house, and often like we do, we try to take in if there's any clues outside of the house that will help us begin to understand how things are going inside. We get to the front door, and before we can even knock, a stern, frustrated and intimidating woman answers the door and basically blocks the threshold. And she says to us, if you're not here to help with our request for assisted dying, then you can just turn around. And that's not really what we had come for. We had been asked to do a palliative care consult. But we said to her, you know, we're here to help. And for some reason, she just let us in. And so in we went, and we met about 8 other family members who were waiting in the living room, as you know, stern and frustrated as the woman who met us at the door. For some reason, they parted, and we were able to get through these sort of family advocates and meet Jerry, who was sitting on a couch in his living room. He was sitting cross-legged, and he was facing his big bay window, which often people do position themselves looking out the window when they've been feeling breathless, because they can see the panoramic view and the leaves on the trees blowing, and it can often give people a sense of less breathlessness. But there he was. He was emaciated. He had a sallow look to his skin, and he was wearing oxygen on his face. And despite his desperation, he gave us a little bit of a smile and warmly welcomed us to listen to his story. We spent over 2 hours in his home. Essentially, we were consulting with a man whose family and he had been left in the dark for his entire illness. We learned this in the 2 hours we were in there. Never during his illness had anyone really invited him to know more about the natural history of his illness and how things would unfold. And he thought that his only option was to get a transplant or to suffocate. So we said to him, you know, if your breathing was more comfortable and you were able to remain independent for longer, would you consider putting your decision about assisted dying on the back burner for a while? Admittedly, we were looking for a little bit of time to convince him that suffocation was not the alternate road to MAID, and that we could provide him some comfort. So we were very relieved that Jerry agreed to try some medication for his breathlessness, but he said he would only give us 1 week to make him feel better. This is often our lives as palliative care specialists. We're often thrust into the care at the 11th hour with the feeling that there's an impossible expectation that we're going to assuage people's fears about dying. And this is not something that happens just once. It happens over and over and over again, where we meet these people seeming like at the end, when multiple teams have interfaced with the patient, many hands have been involved, and yet we meet them and they're bewildered. So this particular gentleman was led to believe his entire illness that he had 2 options, lung transplant or suffocation. And then he was told there was going to be no lung transplant. He was desperate, but we had a week. We were given a week.
So this is I don't know. I feel like that's like, thanks for taking us on that story. I loved how you said we, because I felt like I was going in there with you, Sammy. And to all the people who are joining us in the audience, like I think what we'd like to do now is to kind of go a little bit upstream in the journey before Sammy walks through that door with all of us in there, and kind of imagine what happened along the way that could have what was their story like from the patient and family experience. But while we're doing that, it would be amazing if people can type in the chat, the question, not the chat box, the question and answer box, if they feel that the story where this case study we're using, where palliative care providers feel like they're coming in at the 11th hour, is something that resonates with them. So you can be typing that in while we go to the next slide and just tell you a little bit about the 5 years before. So I think we'll do a little bit of back and forth here, Sammy. So I think when you told me about this case, what really happened was IPF is a lung disease, and he was diagnosed about 5 years ago, right? And so when he was first diagnosed, there's probably this opportunity with his, the diagnosis moment, that bombshell moment. And I think these were some of the things that were said.
Yeah, so when he was first diagnosed, he was told, okay, by his doctors that this is a chronic illness, but don't worry. We have amazing teams involved here at the hospital. I'm a specialist, I'm a respirologist, and, one of the best in the country. We're exaggerating a little bit with our with our case here, but just bear with us. We have a great team here, and let's get you started on treatment, was what he and the family were told. And, the family responded to Jerry, Jerry, you have to think positively, okay? Don't lose hope. They said they're going to start some medication, and, hopefully this will cure the illness. So stiff upper lip, Jerry. We're going to get through this. Rah, rah, rah.
Yeah. And then there's this period, I'm guessing, of where there's sort of this maybe stable period. They're getting treatment. He's stable, about stable-ish. He has less appointments with his family physician. And, at that point, the providers were saying things like, every time he came to the clinic, hey, you're looking great today, Jerry, keep it up. The patient and family noticed things are worsening slowly, but he's still able to function as he was. And it's sort of like, maybe it's the treatment that's causing this decline. It's not really the disease. And they get very busy with these appointments, but their regular checkups, they get anxious before, and he's assuming that the specialists in their team are sort of replacing the kind of care and continuity that they were getting from their family practice, from their family physician. I'll pass this part to you, Sammy.
Okay. So some time goes by, and his stamina is decreasing. He is feeling more breathless, and he's starting to need more oxygen. At first, he was wearing it just at night or when he was moving around, but he's beginning to notice that he's needing more of it and wearing it more often. So he has 15-minute appointments, and mostly they're focused on his oxygen levels, and they change his medication because the one that he was on apparently, they don't know why he changed his medication, but they changed his medication. And unfortunately, they run out of time to talk about his decline and his physical function and his shortness of breath. The daughter catches one of the team members, outside, and says, his oxygen levels keep getting increased. What's the meaning of that? How much time do we have? And the doctor said, don't get ahead of yourself. We don't have a crystal ball. Let's cross that road when we get to it. Let's just, he's going to feel better with his oxygen, and we've changed the medication, and, we have to think positively.
Let's wait and see. So it's now 3 years into his diagnosis, and they sort of break the news that he's getting worse, and really, he will need a transplant if he wants to have, increasing quality of life. And so they discuss the process of the transplant. They get into all the technicalities, and, it sort of gets over the heads of the families. And the wife basically says, what would you do, doctor? And if this was, your husband or your spouse and a partner, and he says, the options are transplant or death. And so your best bet is to get stronger to have the best chance at the best quality of life. So that's what they sort of walk away with.
Mm-hmm. And so he goes home to get stronger, and the whole family mobilizes to get him stronger. He starts to have regular appointments again with the respirology team and the transplant team. And despite their best effort to get stronger, his physical condition is worsening. And everyone that's close to him is starting to get worried. And the wife reassures him, look, no news is good news. They'll tell us if there's something we need to know. She notices he's not eating. And they were told that he was supposed to get stronger, especially if he's going to qualify for a transplant. And so she calls the team behind his back, her husband's back, and says, you know, this is what's happening. I can't get my husband, like my husband doesn't really have an appetite, and I keep trying everything I can. And do you have any advice? And they say, you know, you've just got to keep up the effort. You guys have to continue to fight and try your hardest. You know, you have to try to get him to eat a little bit better. And, you know, we'll arrange a dietitian to come in and help you guys out. And, you know, the good news is, the respirologist said, that now we're going to take him off that medication that he was on again. And we are going to see if he's available for a clinical trial. And clinical trials are, you know, not for everyone, but let's see if he'll qualify for a clinical trial. It's a newer treatment option. And so Jerry's wife was okay with that.
And this is now almost 4 years into his disease, a year before, you know, they call Sammy to come in. He's going to the emergency department a couple of times because his shortness of breath is getting worse and worse. SOB stands for shortness of breath. And he's increasing with anxiety and fear because what's going on in their mind is he's scared to suffocate. And he's given more oxygen. They really notice there's no infection. They send him home on steroids, and the same pattern keeps happening over and over.
And then we meet him around the time of our home visit. And it was just after he was told that he wouldn't qualify for the transplant. Yeah. And right away, he's no fool. He was not going to take the suffocation road. He requested medical assistance in dying.
Yeah. So we really went into depth in this case because we're going to revisit it again. But I did see when we asked the question of, is this your experience of what could be done? I mean, I kind of want to bring you into our world 4 years ago where, you know, that this is a nice quote. There comes a point where we need to stop and pulling people from out of the water. We need to go upstream to find out why they're falling in. And this was sort of our life to sort of put a personal twist on things. Like both Sammy and I really felt frustrated by this experience. And my experience is watching my mother die 30 years ago, and that experience of, you know, not using the words palliative care and people being scared. And this same idea of what I hear when I talk to patients and families today as a researcher. So, you know, things have changed, but so much is the same. And we know there's a death denying society. We know people are, you know, equate palliative care with death and dying. And so what can be done? Can anything be done? Or do we just sort of throw up our hands and, you know, change professions, which, you know, we both considered maybe in different ways. So what did we do? Sammy and I really, we thought. We had lots of cups of coffee to talk about this. We really realized there was something about, we kept seeing the patient stories, and we really felt, we saw the bad stories, the not so good stories, the 11th hour stories. But then there were a handful of patients who felt more prepared, in control. They had more choices. They were just more aware. They were in the know of what was happening. And we really tried to think what was different about them from, you know, 99% of the patients who were just sort of frustrated, overwhelmed, anxious, and scared.
Hsien, were you going to ask the participants a question?
I think because of time, I was sort of going to bring them along. And when we got into what our solution was, maybe they could react in the chat box then, like right. the Q&A box. Is that okay?
Yeah.
So what did we do? Maybe you want to take the next part of the story.
Sure. So as Hsien said, we just kept seeing the same pattern over and over and over and over and over again, where these poor people were at the end of progressive life-limiting illness and seemed to really not understand where they had come from, where they were at, and what to expect as things unfold. And all of the anxiety and fear was amplifying their symptoms and making them sleepless and making pain worse and making breathlessness worse. And we just asked ourselves over and over again, why? Why, when so many other teams have been involved, are we meeting people who have known illnesses and yet they seem to be in the dark? So we untangled all of it as best we could, like Hsien said, over lots and lots of coffee. 4 years later, we deconstructed, reverse engineered all of the bad and the good parts of people's stories and tested them out on people and repackaged them to be upstream in a way that we thought was palatable for people without focusing on, what to expect when you're dying, but more, what are the types of things that we can offer people to help them have a journey that moves from an in the dark to an in the know journey, woke, invited to be woke, invited to have more information so that they could feel more in control through their illness journey. And therefore, maybe we, in a few years, we would meet people at the end who weren't as freaked out and in the dark. And so we repackaged all of that and came up with 7 keys, we call them, 7 mindsets, 7 chapters, 7 skills, whatever you want to call them. There seem to be 7 buckets that would help people shift from an in the dark to an in the know experience.
So before I show and reveal these 7, because these took us like years to come up with and lots of coffee, I would love if people, while they're listening to what we're about to say, is maybe in the Q&A box, maybe you can put some of the solutions that you think would be successful at, going upstream or redefining palliative care so that it would be more palatable to the average person. So you can put some of your ideas in there. I am seeing them all as they come across. And then we're going to share with you, just in the interest of time, the 7 skills that we came up with and I think where the innovation came from was, it wasn't just from our perspective, the language, the metaphors really came from people we interviewed, the bedside stories that, the patients that Sammy has served. And I think it is palliative care, but without the language.
Oh,
Yeah, go ahead.
Hsien, I forgot to say, one of the most important pivots that we made was that we both had spent so much time trying to influence healthcare providers, and where we both feel that is still really important to teach healthcare providers what does a palliative approach look like, and that it should be everyone's business or everyone's responsibility, not just specialists. All of that work is extremely important, and we thank Pallium and LEAP for taking the bulk of that. But we also felt this desperation that a person should not have to see a healthcare provider to be able to access this information. And also, they shouldn't have to just by chance end up with a healthcare provider that's comfortable with these skills. And if you didn't have a healthcare provider that was comfortable with these skills, you may not get invited into receiving a palliative approach. So we pivoted away from focusing solely on healthcare providers and decided to offer these podcasts to citizens of the world. And that was our biggest challenge, because we're so used to the language we use in healthcare that not only did we have to take what happens at the end and repurpose it upstream, which we haven't worked up here before, we had to do it in a language that would be received by average citizens of the world and not be scared. Like my sister said, when I told her we're going to write a book that's called What to Expect When You're Dying. She said, don't bother. No one will pick up that book. We said, okay. So we didn't want to avoid death and dying. We didn't want to avoid palliative, but we knew we couldn't sell it that way right at the beginning. So this is for citizens. We did it in a language that hopefully is agreeable to the average person. And yeah, this was for them.
Yeah, and we realized healthcare providers are citizens too. They can be patients, they are families. So if it worked for that group, it would include healthcare providers. And the name of the Waiting Room Revolution, which is the name of our podcast, and you can go to the website of the same name, or you can go on however you get your podcast and download now. And there are whole 7 keys is the focus of our season 1, which just ended. We're now in season 2, but we want to share with you because the season 1 took a long time to come up with our really good ideas. But it was because this idea of the waiting room where the patients and families were, that was where the revolution needed to happen. And it wasn't just healthcare providers such as yourselves. I'm seeing all the comments in the box about who have to get it and know the language, they could have it too. So I'm going to now show you, we're going to reveal the 7. Hopefully we've enticed you enough to keep listening. And this is what the website looks like if you go to thewaitingroomrevolution.com and how you download it. And some of our guests, Sandy Buckman is there and Dr. Pereira, José was just on. Here is the infographic with our 7 keys. We're going to talk about each of the 3. We're going to connect it back to the case. And in the chat, if you've sort of put in your thoughts, you can be reacting to the keys as we talk about them. So I'm going to zoom into the first few, and I'll just kick it off and we'll go back and forth. So Sammy, what is Walk 2 Roads?
Okay, I'm going to describe the first key, but before I do that, I just wanted to say one more thing, Hsien. Yeah. To everyone was that, okay, so now we realize at the end of doing all of this, that what we really did was help people, patients and families learn these keys and skills so that right from the get-go, if they're diagnosed with a progressive life-limiting illness or really any illness, but specifically a progressive life-limiting illness, that they, if they follow these, can extract a palliative approach from the healthcare system without waiting for it to come from the healthcare system. So without doctors and nurses maybe even realizing it, if a new type of patient comes to them in waves with this new skill set, where we bring them from the back seat of their healthcare journey to the front seat of their healthcare journey, a more activated, empowered patient and family, that these 7 keys will, again, secretly allow them to get a palliative approach out of the system and beyond without realizing they're even doing it. It's genius. Oh, okay. So now you want me to describe the first key. Okay. So the very first key, we would argue, is one of the most important. We're going to say that for everyone. But it's called Walk 2 Roads. It's basic, and I know we're speaking to the converted, and I know everyone listening here will think this is not completely sexy. But the truth is that most people, when they have an illness, they feel much more comfortable when they walk the road of hope. Hope, 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 hope. Positive, positive, positive. Cheerleading the whole way. And they feel that if they dare look down this other road, the what ifs, the what if things go sideways? What if it doesn't work? Or, hope for the best, plan for the worst. If they even entertain this idea that they are betraying their hope. And so this whole episode is about the fact that you can do both simultaneously, that you can hope for the best and plan for the what ifs at the exact same time. And that one does not negate the other. The other thing is that in this episode, we help people understand that hope can remain from the beginning to the end. But the only way that it can transition appropriately is if people have an idea of where they're at in their illness and a dose of reality. so that people don't get stuck in the early versions of hope, like hoping for a cure or the whole way along. So it's about hoping for the best and planning for the worst.
And planning for the what ifs. Yeah. I'm just looking at the time. We actually spent like an hour talking about each of these, and then we edited them down to the best 20, 40 minutes, half an hour or so. We'll have to be a bit speedier here, but zoom out is the second big key. And, our second episode, where it is this idea, some people mentioned it in the chat box, the Q&A box, about zooming out, talking about the disease trajectories. And that often we get stuck in the details, the weeds of the disease. We can't see the forest from the trees, i.e. the blood cell counts and the scan, this scan, that scan. And we lost, and patients and families really have no idea about where they are in their illness and what to expect. So they don't want to plan for their death, maybe, but they do want to prepare for what's ahead. They don't want to be caught off guard, really. So the zooming out is a skill that it's hard, it is a really important one to understand the big picture of their illness. And this is the disease trajectories piece. Sammy, this one's go ahead. But know yourself.
The third one is know your style. This one is really helping patients and families, know themselves by looking in their past and seeing how they have coped with challenges in their past. What are their natural coping mechanisms? What are their natural personalities? And this idea that, people die as they live, that those deep-rooted coping mechanisms and personality styles probably don't change when people are going through a serious illness, but you can learn about who you are and how you're likely going to journey by knowing how you've done it in the past. The other thing we talk about here is that people can mix and match their styles. So if you tend to be an ostrich, guess what? You're suddenly not going to become a lion. But we tell you what it's like to be an ostrich when you go through a serious illness and all these other styles. So it's about knowing your own style so that you can predict how you're going to perform, for better or for worse, without changing people, and know how to saddle up with someone with a complementary style so that you guys get the information that you need.
Yeah, and I think I've learned this so much from you that people don't ask enough about how they like information and how they just sort of go along with the standardized conveyor belt, and they lose their sense of self because they haven't really spent time to really be, I'm the kind of person who likes information. Why don't I have the information? What's stopping me from asking questions? And that's a nice segue into customize your order, which is really about this idea that there is a standard of care. There is sort of, options and treatment options, but you have to connect your goals and values, your preferences to that. And we have language like advanced care planning and goals of care, but when do you do that? It should be throughout the whole thing. We should always be connecting what's important to us, what are the trade-offs we're willing to make. And so we sort of talk about this through this idea of customizing your order to what's right for you. So as we're talking about these keys and the metaphors, feel free to respond to them in the question and answer box. I'm seeing quite a lot of action there. And we are going to connect these 7 keys back to the case very shortly.
Very shortly means Sammy, hurry up.
No, I'm just flagging for us because we won't have time for answering questions for folks. Okay. Yeah.
So number 5 is expect the ripple effects. So this episode is about the fact that the patient is the star of the show for sure with the illness, but that there is this ripple effect on everyone around them. So it's about the person's inner crew, their family, their people. It's about the fact that an illness experience has an effect on the people around them, and their own journeys count. The family and the caregivers count in many ways. They're an important source of information for the healthcare teams, especially when you work in people's homes, but every healthcare environment, but also that they are experiencing their own journey. And usually they come into this role just, by chance. They happen to be the wife or happen to be the daughter and really don't get a roadmap in terms of what the illness is going to look like for a caregiver and what they've actually just signed up for without interviewing. So this is a shout out to the people that are also affected from the illness.
Tegurit is the idea that, the patient and family have key information, they have a key role, and they're going to have a role in connecting the dots in the system. There's no perfect system. There's no one super coordinator who will know everything about you and every resource. There's going to be a role for patients and families to be the homing pigeons or the glue between things. And if you're not the person who likes to do that, then find someone who is, or get the notebook to try to keep track, because that's a key piece to not fall through the cracks and feel overwhelmed, especially when there's many care providers involved.
And then the number 7 is about inviting yourself. It's really, really just asking patients and families, giving them permission to ask questions. And it's all about painting a picture of a journey where people ask lots of questions versus a journey where they keep the questions to themselves and what that might look like. So it's about inviting yourself to ask and not wait for your trusted healthcare provider to invite you.
Yeah. So like I said, we spent a lot of time coming up with these keys because we really wanted them to be things that were actionable and not philosophical or, theoretical. We talk about them in depth in our podcast. So if we've piqued your interest at all, please, waitingroomrevolution.com, check it out, download it, listen to us. We're in the top 3% of global podcasts. We just started. So we're really excited that many people are excited about this conversation. And what I'd like to do now, we have about 20 minutes left. We've never done this before, but we want to connect these keys to the case that we talked about, Jerry's case, and share with you some of the language that we think providers like yourselves could use that sort of incorporate the elements of these keys and could change the storyline for someone like Jerry. So
yeah, maybe we mention that since the podcast has been out, we've had really overwhelming positive feedback from healthcare providers who have listened to the podcast. And that is a little bit of a surprise to us because, like we said, it was meant for people, for just average people. And we've had lots of doctors and nurses and social workers thrilled to listen to the podcast and have even found that they have learned things from the podcast as well. And, we've been scratching our head and wondering, why is that the case? Because there's all these amazing tools out there to teach healthcare providers how to have better communication for sure. And at this point, we think it might be just the very simple lay person way that these concepts are described. And it might be giving healthcare providers a more natural way to introduce these concepts without relying so much on a tool or a very rigid structure. I think it's the natural vibe of the content that people are reacting to positively.
Yeah. And exactly like you said, the plain language and how do you sort of integrate? This is really the key. Like we talk about integrating palliative care into, regular care, but how do you actually do that? How do we achieve that? And so I think we're starting here with language and concepts to integrate them. And so as we go through, revisit this case step by step, I invite people to look at this and see if this is sort of a realistic case or something you might have heard someone say at one time. It shouldn't, we've heard these in different ways. And then maybe what would you say? How could we have turned this so this was an opportunity to integrate early palliative care approach? So you can do that in the Q&A. We're looking at that and to generate discussion amongst your, the people on the call. But in this, when they first got the diagnosis, Sammy, what could have been said differently here?
Okay. Well, right from the get-go with idiopathic pulmonary fibrosis, same as when people get COPD or cirrhosis or some non-curable cancers or ALS, et cetera, come on, we know this is not a chronic illness. A chronic illness suggests that something stays the same over time. These are progressive life-limiting illnesses. So, someone at the beginning of a diagnosis might offer their patient that this is a condition that is non-curable. and it changes over time. My team and I are committed to trying to help you have the highest quality of life. No two patient journeys are the same. And yes, there's lots of uncertainty, but I'm here to help you walk two roads, to hope for the best and to plan for the what ifs along the way. And to be more honest about what the medication does and doesn't. You know, the medication we're starting is to help try to slow this illness down as much as possible, although we can't cure it. It's setting up realistic expectations gently right from the beginning.
Mm-hmm. Mm-hmm. And I love Walk Through Roads because it's not about planning for death. It's about hoping for the best, but planning for what ifs. You know, what if it doesn't work as well? What if it stays the same? You know, what if they, you know, you start to have trouble getting out of bed? What are you going to do then? So I think these what ifs are much more palatable than this idea of how much time do I have left? Okay, let's keep going to the case. The second part of the case was when, oh, this is the hopeful period. I don't know, the honeymoon period, the I don't know, called the gray, but where people are hoping that the treatment, not in IPF, but in cancer often, they're hoping that this is going to cure them, put them in remission. And so they lean into the cheerleading. You're looking great. And they just are just, you know, so many people say, I'm just hoping the treatment works and let's not think about anything else. So how do we manage this piece differently?
Yeah, so I mean, when things are sort of stable-ish, you know, this is an opportunity for healthcare providers to do really important work. So first of all, many healthcare providers who work upstream have told us that the most important thing that they do is renew their vows with their patient and family, and basically say, you know, I want you to know that I'm here to help you. I'm here to help you understand your illness better, to help manage your symptoms, and to plan ahead for the future. I've cared for lots and lots of people with this particular condition. And if you wanted me to, I could describe this illness to you in general terms. You know, some of my patients are even curious about what the average timeline looks like in this particular illness. And oftentimes people will ask me, where do they fall on this timeline? You may also offer to them, you know, I'm not sure if you're the kind of person who has looked things up. Last appointment, you know that you have this illness called idiopathic pulmonary fibrosis. Most people, when they look this up, start getting worried. And many of my patients tell me that they worry about suffocating to death. And so you assuage that fear. You tell people that, you know, that is not what happens when people have idiopathic pulmonary fibrosis. So it's demystifying their biggest fears at the beginning, even though breathing is affected more and more over time. We don't let people suffocate. We have medications to help treat the symptoms the whole way along. And most importantly, this is a time when you really want to figure out the patient's and family's natural style, and also how much information they want, how they like to receive information. Do they like it straight up, frankly, or sugar-coated? A little sugar, lots of sugar. This is how you're going to know how to unfold the facts and the reality for them.
I know, I was laughing because that whole sugar-coated, it sounds like but everybody understands that. I've heard that so many times, and that's like language that everyone can do, like it's straight up or sugar-coated, and everyone can understand that. That doesn't scare people away. The next part of the case is this. So now there's worsening, you know, and they're noticing things. The daughter even asked, how much time do we have? She got the crystal ball answer. And so I think there is this question in the box that I think fits nicely. How do you manage how do you do this for the patient and the family? And I think they're connected, because everything you're saying is really not only for the patient, it could be for the family too. But maybe you can talk a little bit about this in this part of the case.
Sure. Again, this is a little bit repetitive, but you'll get the idea that at multiple points through an illness journey, the most important thing healthcare providers can do is invite people to know more about their illness journey. We're not forcing people to know. We're not forcing people to have more information than they want. It's about inviting. It's been a couple of years since you had this illness. How about we review it together? How much do you remember about what we told you the last time? Are you curious about where you're at now? Does your mind ever wander into the future and wonder what's next? Let's talk about your symptoms. And you might give them self-management skills for breathlessness so that they feel like they have something they can, because families are the first responders in the home, right? And most patients spend most of their illness at home, not in healthcare settings. You may introduce the idea that if the symptoms ever get to the point where they're more complicated, that we have other partners to pull in, and maybe introduce the idea of palliative care specialists before the 11th hour. And here's the part about the family is that it's important to let the families know that they have an important role, and that they themselves will have a unique illness journey separate from the patient. They're encouraged to see their own family doctors and take care of themselves, because eventually it's like a house of cards. If the caregiver goes down, the house crumbles. So inviting the family members in, as much as you invite the patient in, is really important. And then the other thing is, to answer the question, is really, this doesn't have to be done together in one room. You might offer families opportunities to have access to you and information separately, because people are at different stages of being ready for more information.
Yeah. So we're in our last 10 minutes. What I'm hoping, if people can let us know how if this is helpful in the case, that please do that. Let us, we're trying to finish the case, quickly, but you could see how these are tied together, and you can see how we spend, 30 minutes talking about each of these keys individually, and other healthcare providers of how they integrate them. But yes, and if you have burning questions, put them in the chat now, and we will try, and I'll do my best to make sure we have time for them. Now this is in the case we're moving along. He gets the news about the transplant. What would you do, doctor? These are your options. So I think, you're saying.
I mean, this is even more important, where you have to hope for the best and plan for the what ifs. And while, they're deep into exploring options of lung transplant, we need to make sure that we're also focusing on quality of life. And we won't read all of this out, but, it's really, really important that people understand that their only option isn't transplant, that we can help people be the best that they can be the whole way along, and not keep people in the dark until they feel that the carpet's been ripped from underneath them. And we need to make sure that he understands that if he doesn't get a transplant, that doesn't mean that he's going to suffer to death, because most people, as you guys know, think that either they're going to, burst into flames or have terrible pain come upon them, or suffocate to death. And that's not what usually happens.
Yeah. And I think this really emphasizes it's the same keys, but every time there's events, sentinel events, whether it's a hospitalization or what have you, which I think is the next part, this is another opportunity, a natural opportunity to revisit all of these. Are they walking two roads? How do we zoom out? And this is what's happening here, right? This conditioning is worsening. And I'm saying I'm jumping ahead to what the orange is. See, I'm learning from you, Sammy, right in real time. But these are some of the quotes I know that we've learned that people have said that have been very helpful.
We can go on.
Okay. And the next one was his fear of suffocation. Yeah.
And so again, you can see, zooming out is really important. When people end up going back and forth to the emergency room, we can offer it as a learning experience for them. What brought them into the ER? What were the symptoms? What did they do in the ER or the hospital? And do we want to try dealing with those things at home and put action plans in? Start offering home visits or virtual visits or phone calls, so that they know that you're still in it with them. And, beginning to reintroduce this idea that, where they're at in the illness, and, would they want to know if you thought that they were in the last year of their illness, and what that might look like, and what that might look like at home, and what that might look like for the caregiver. People need to be offered that information, because it's their body and their illness, and we shouldn't keep it a secret from people, especially when we know that they've entered into the last year.
Yeah, I know we've talked about, this is really about informed consent and even health literacy on some level. And those are terms that maybe we on the call would understand, but average, lay people might sort of not get it. But this is the final part of the case where they meet you, Sammy, and hopefully the story is different because of all those things you talked about.
Yeah, I mean, if we did this the right way, if we introduced concepts of walking two roads and zooming out and knowing people's styles and appreciating the ripple effect on families and empowering families to ask questions and take care of themselves, et cetera, et cetera, et cetera. Hopefully, by the time Jerry gets to the point where they tell him that he is no longer a candidate for a transplant, that he's remained comfortable the whole time, that he's had reasonable, good symptom control, and that he the whole time and his family have known what the possibilities were and what the what ifs were, that he feels supported and treated as a person and has no regrets. Too many people say to us, why did they never tell me? I don't understand. You're telling me people knew that this is the way things were going to go and no one told me. So we don't want people to have regrets. We want them to be able to customize their care journey to best match who they are as a person and not feel that they are on a conveyor belt. They knew he was going to decline at some point, and they've been preparing for that ever since the beginning of his illness, while they have continued to live with hope. Mm-hmm. And so where they are aware of MAID, and for some reason, for him, it gives him some comfort that that's legal in Canada. It's not something that he wants right now because they're okay, and he's put it on the back burner.
Yeah. We have our final 2 minutes. I think again, with our podcast, we talk way more in depth. And the best thing is it's not just us talking, we have guests come on and we tell patient stories. So it's much more, it's entertaining, and that's what people have said. I hope that you check it out, but I want to leave you with the real conclusion of what happened in Jerry's story. And I'll leave the final word to Sammy.
Yeah. Okay, so remember we met Jerry. He's our 52-year-old with idiopathic pulmonary fibrosis, and he was told that he had no transplant option. And because he was basically read that he was going to suffocate to death, he asked for assisted dying. We went in and did our consult, and he gave us a week. He granted us 1 week to make him feel better. And so we started him on medication to help with his breathlessness. We put supports in the home. We gave him some non-pharmacologic approach to breathlessness. And unfortunately, he didn't get comfortable fast enough. And he lost faith in our ability to provide him with the level of comfort he needed. And he went ahead with assisted dying. And in a way, you can't blame him because he was in the dark the whole time. It's impossible to enter on the scene at that 11th hour and change the course of a healthcare journey that started 5 years before.
Yeah. And that's what we're trying to change in the Waiting Room Revolution podcast. So I know we're at time. Thank you all for taking time. Thank you to Palliam, for an echo. And Jose, oh, there you are.
That's fantastic. Hsien, Sammy, fantastic webinar. I think you could see from the comments that it resonated a lot with all the participants. I would really, again, encourage everyone to spread the word, spread these podcasts. I can't wait for this one, and the others to come out. Please spread it. Please encourage friends. Share it with families, because I think it's important. Even if you're not ill, I think it's important to listen to this because it empowers society. So, to you and Sammy, amazing work done, and keep up the great work. So we'll all see you hopefully pretty soon for other podcasts, and I'm sure we'll have Hsien and Sammy back at some point, hopefully not in the too distant future. I think they've got enormous amounts to share. So from us, thank you very much, and see you all soon. Keep safe and keep well. Bye-bye.
Bye, everyone. Bye.